Alrighty, so drugs for heart failure. So, again, heart failure is a progressive, often fatal disorder. Most of the time with heart failure, we're looking at having left ventricular dysfunction. But regardless of whether it's left-sided or right-sided, we're going to have a decrease in cardiac output, which will inevitably lead to insufficient tissue perfusion and potentially signs of congestion. So, our list of heart failure therapies that we're going to be looking at are going to include diuretics, RAS inhibitors, vasodilators, beta blockers, cardiac glycosides, dopamine, which is another form of an inotropic agent, and potentially device therapy. The overall goal here is to improve cardiac output, reduce the severity of congestive symptoms, and decrease cardiac workload. All of these will help to promote cardiac health and improve longevity, as well as improving the quality of life for patients with heart failure. We do all of this by manipulating preload, afterload, and contractility. So when it comes to heart failure, I guess that works. We have several stages, and we kind of have this stepwise approach towards prioritizing which medications we go with for treating heart failure. Here at the bottom, we're looking at a lot of things involving lifestyle modifications. So we're going to be looking at treating hypertension, diabetes, dyslipidemia. A lot of that will occur from changing your diet, increasing your level of activity, exercise. Sometimes we'll also use medications to treat them, such as with ACE inhibitors, ARBs, or potentially other medications. And if patients don't respond well to those medications, we may bump it up here to beta blockers. And then from there, we can continue with even further levels of sodium restriction using diuretics, and then also considering using digoxin as a potential. From there, we're looking into more medical procedure forms of therapy, resynchronization, revascularization, mitral valve surgery. Then we get to up here where we're looking at aldosterone antagonists, potentially inotropes like dopamine. And from there, this is where we're looking at quality of life, comfort care, and potentially moving on to hospice. So stage A, come on. Stage A, this person has a high risk for heart failure, but there are no symptoms just yet. Stage B, where we have right here in this kind of reddish color, we have what looks like structural modifications, remodeling in response to stressors that are put up against it, that a person has to experience over time, but we don't yet have symptoms. Stage C is what we're going to be, where we're going to be noticing really a lot of times the onset of symptoms. We may have some down here, but this is where they become pronounced. And then stage D is going to be where we're looking at a lot of times comfort care, quality of life, maybe with a VAD or transplantation, we might be able to prolong life a little bit. VAD being this ventricular assist device where literally we have a pump that sort of mimics the left ventricle as much as we can. There we go. Alrighty, so the purpose of these medications for diuretics, ACE inhibitors, and decreasing manually the fluid and salt intake, all of that, the purpose of that is to decrease intravascular volume, which will inevitably lead to a decrease in preload and afterload. What that does is that will take a lot of the stress off of the heart in the first place, allowing it to kind of recover a little bit, potentially, or at least not progress the disease that much faster. Cardiac glycosides, which is going to be our digoxin. The main thing we have here is that it improves contractility, leading to an increase in cardiac output. ACE inhibitors and ARBs, these will inhibit angiotensin II effects, which is going to be aldosterone primarily, along with vasoconstriction. And doing this will prevent the fluid reserving, I guess you can say, or holding on to fluid by holding on to salts. And so by eliminating aldosterone or reducing how much of it, I just dropped my pen. There we go. By reducing how much aldosterone we have, we reduce how much fluid is in there, leading to the heart not having to work quite as hard. Beta blockers will simply inhibit sympathetic nervous system effects, so we're going to limit how much the heart rate ramps up in response to what the heart feels is low blood pressure or inadequate oxygenation. And then we can potentially use pacemakers to synchronize the ventricular contractions if there are issues with dysrhythmias as well. So diuretics, RAS inhibitors, and beta blockers, these are all going to be our first-line medications, as you saw also on that stepwise chart. The stepwise chart does put diuretics up here, but they are considered to be a first-line if there is, and that's important, if there are signs of excess fluid accumulation. Outside of that, RAS inhibitors, beta blockers are great first-line medications towards helping with heart failure. So with our adrenergic antagonists, we have alpha antagonists and beta antagonists, or beta blockers. In general, beta blockers are good for angina, hypertension, but they're no longer the first-line medication. Dysrhythmias, especially with regard to tachydysrhythmias, myocardial infarction as the emergency response to an MI, where we want to take pressure off the heart in a very, very quickly to try to prevent further damage until we can find some sort of long-term resolution. And then heart failure. This is now a standard therapy, but it was once an absolute contraindication. That's important to remember. So with beta blockers, or beta antagonists, these protect against excessive sympathetic stimulation. So when we have a patient with heart failure, they're going to be sending out signals saying, hey, we don't have enough oxygen, or hey, the blood pressure is too low, ramp up the heart rate. And they're going to be ramping up the heart rate by promoting sympathetic stimulation. So beta blockers block excessive sympathetic stimulation. They also protect against dysrhythmias, especially the tachydysrhythmias. Unfortunately, the problem with beta blockers is that they can use or can promote a worsening of heart failure and fluid retention if the dose is not very low. From my understanding, the way that works is if the beta blockers work too well, if the dose is not very low, what we're going to end up having is the heart rate is going to go down progressively until it gets to the point where we have heart failure plus too low of a rate to kick out much fluid, so we're going to have even greater levels of congestion backwards from whichever side of the heart is not working, and that's going to lead to even greater levels of congestion. So let's say it's the left side of the heart, and at this point the person's experiencing symptoms of congestion, and the backwards effects of left-sided heart failure involve the pulmonary circuit. So if the heart is doing okay, pumping at, say, 70 beats per minute, and we give them a beta blocker and it dumps it down to 55 or 60, and they're at that point not even able to put out that much cardiac output, all of that extra fluid can then accumulate inside the lungs, promoting even greater congestion, because the more fluid you put into a space, the more pressure and hydrostatic pressure that we're developing, allowing for the fluid then to third space, make all those congestive symptoms worse. Beta blockers can also cause fatigue and depression, hypotension and bradycardia. Hypotension and bradycardia, of course, if they work too well or if they are given a too high of a dose, we're going to dump their blood pressure and dump the heart rate. So beta blockers in general, the actions, they affect both beta 1 and beta 2 receptors. And you can think about which ones affect what by remembering that beta 1 affects our one heart, and beta 2 receptors affect our 2 lungs. So for propranolol, which is an older beta blocker, the mechanism of action here is going to be that we block both beta 1 and beta 2 receptors. With beta 1 receptors, the general positive benefits that we have from this is that we have a reduction in heart rate, a reduction in the force of ventricular contraction, which will then lead to a decrease in cardiac output, and a decrease in the impulse through the AV node. All those are great for heart failure. If we have a patient whose heart is working too hard at the given time, not every person needs to go onto beta blockers. For renal, we have another benefit of having renal or renin secretion suppressed. Renin will inevitably lead to the release of angiotensin II, aldosterone, and promote vasoconstriction, which will all increase the workload of the heart, thus progressing the disease process, making the heart failure worse. We have also some beta 2 receptor blockade actions that are not so positive. So in the lungs, we have bronchoconstriction. In blood vessels, we can have vasoconstriction. And in the liver and skeletal muscles, we can have decreased glycogenolysis, which is the breaking down of glycogen into glucose in times where we have low blood sugar. So propranolol can be helpful for hypertension, angina, MI, and two kind of unique ones that are specific only to propranolol are prevention of migraine and stage fright or performance anxiety. Propranolol has actually been used a lot more for stage fright and performance anxiety than it has, from my understanding, of specifically for heart failure or for any other form of cardiac condition because of the number of side effects that can occur. It doesn't mean it's not used, but there are other medications that most prescribers prefer to go to because there are a number of adverse effects. For example, bradycardia, AV heart block. A lot of these are pretty typical for any kind of beta blocker because you give too much, you have the risk of slowing the heart down too much. AV heart block, this is a series of 4 rhythms that can occur that basically, as we try to send a signal down from in the heart through the SA node to the AV node, down through the bundle branches and the Purkinje fibers, all of which is required to cause the heart to contract, we can actually form sort of this block of sending the signal through the SA node, passing through the AV node, and kind of skip a heartbeat. That skipped heartbeat can kind of look in different ways depending on how the EKG looks, and you'll learn more about this in acute 2. Some of them are mostly harmless, other ones can be very dangerous. So we can also cause an exacerbation of heart failure through promoting greater congestion. And then if we have too abrupt of a withdrawal, we can lead that to rebound tachycardia. Our bodies tend to accommodate these beta blockers. And if our body recognizes that they need to kind of amp up the SNS activation in order to allow the heart to beat at the correct rhythm, having been conditioned to being on beta blockers, then having an abrupt withdrawal, the body won't recognize and will take longer to adapt to the recognition that we no longer have beta blockers in our system. And they're going to continue with this amped up or ramped up level of SNS activation until they recognize, wow, our heart rate now is at 160 resting. We need to calm down. We can also have ventricular dysrhythmias. I don't remember why that is, but it's something to be aware of. Other adverse effects that are not cardiac specific are going to be bronchoconstriction. So that's going to be a problem for any patient that has any kind of a pulmonary problem. So cystic fibrosis, COPD, asthma, any person with a problem with bronchoconstriction, we're going to want to be very careful, if not avoid altogether, using propranolol. It also inhibits glycogenolysis, which can lead to hypoglycemia. This is a problem for diabetics, So we want to avoid this, if at all possible, with diabetics. And because of the fact that it crosses the blood-brain barrier, and I don't know what the mechanism of action is to cause depression, but it can promote depression in people because of that. So, and then also if it causes fatigue, did not mean to make that mark, go away, and sexual dysfunction. Sexual dysfunction is an important thing to explain and educate patients on the potential of beta blockers causing, because it can kind of catch them off guard and surprise them, and they may not necessarily really be aware that that's a side effect for them to report to the prescribing person. And the reason why it can affect sexual dysfunction or promote sexual dysfunction is because beta blockers, I believe this is the way it works, beta blockers, because they're reducing blood pressure, they're going to potentially reduce how much stimulation of the sympathetic nervous system there is to the genitals, as well as reducing how much blood flow can go to the genitals, which is required for any form of sexual action. So they may not be able to function as well, but they may not also be aware that that's the issue. If we educate them on that being the issue, they can then report to us and we can say, hey, all right, let's do something about maybe switching you to a different medication or find a way to treat the sexual dysfunction so you can be happier. Propranolol also has a number of drug interactions, such as working with calcium channel blockers, which are also going to be able to be used for hypertension and can act synergistically to cause even greater hypotension. And because of the fact that propranolol inhibits glycogenolysis, giving it along with insulin or other oral hypoglycemics can promote even greater hypoglycemia. So with general precautions, because of the hypoglycemia, we want to avoid diabetes. Because of the bronchoconstriction, we want to be careful giving it to asthma. And because of the fact that it crosses the blood-brain barrier and can promote depression, we want to be careful giving it with patients who have psychiatric disorders, especially depression. Metoprolol is the prototype for second-generation beta blockers. It is much more selective for beta-1 blockade, which is really, really good because that way we don't have as much in the way of bronchoconstriction nor hypoglycemia. So therefore, it's going to be preferred for asthma and diabetes, but it's still only indicated for heart failure with caution because it can still promote the accumulated congestive effects by worsening heart failure if it's not monitored closely. So cardiac glycosides are going to be our digoxin. This is going to be an inotropic agent, inotropic being that it improves contractility. When it comes to a lot of these cardiac medications that promote increases in cardiac output, they can be an increase in cardiac output either by way of being an inotrope or being a chronotrope. So a chronotrope, that's going to increase the rate. An inotrope is going to increase the contractility. So with inotropes, we're going to be increasing the myocardial contractile force. With digoxin specifically, we actually will also be able to affect the electrical activity and the some neurohormonal effects, which is going to be really helpful. So we're going to decrease heart failure symptoms with digoxin. We're going to be able to increase exercise tolerance, which is huge for heart failure patients. It's one of the main benefits or the main therapeutic actions that we can promote to improve their quality of life and improve their heart failure symptoms and potentially even improve their prognosis. So anytime we can try to get someone to improve exercise tolerance and promote regular exercise, the better. So decreased hospitalizations are going to result from a decrease in heart failure symptoms and the increase in exercise tolerance. So digoxin has a number of neurohormonal benefits, such as it's going to reduce renin release from the kidneys, and a reduction in that release from the kidneys will result in a decrease in aldosterone. There will be a decrease in sympathetic outflow from the CNS, which means we're not going to have as much of that epinephrine, norepinephrine, or direct sympathetic outflow from the SNS, which will prevent the heart from going to a faster rhythm. So we're going to decrease heart rate by doing that. And I guess realistically, it's not decreasing the heart rate. We're going to prevent the heart rate from being jacked up, which would, in doing that, promote a greater workload for the heart. We're also going to increase cardiac baroreceptor sensitivity. So baroreceptors, remember, these are going to be the ones that detect pressures in the blood system. We're going to have baroreceptors in the aortic arch, in the carotid sinuses. So by increasing their sensitivity, what we're going to do here is we're actually going to have those baroreceptors recognize earlier when the blood pressure gets high enough to meet tissue demands. What that means is those baroreceptors then will not continue sending out signals to increase heart rate or increased contractility, which will take off some of the workload from the heart. So instead of, say, the baroreceptors requiring the blood pressure to get all the way up to 130, 135, 140 before they stop telling the body, hey, up the heart rate, we may only have to get up as high as 115, 120. And these are arbitrary numbers, but they're there to make a point. And they're going to get to up to 120, and then they're going to say, hey, okay, we're at the right point now. We can turn off our signals and let the heart relax. For our electrical effects, we can increase the firing rate of vagal fibers. So vagal fibers, remember, this is a cranial nerve. This is the really big one that comes, I think it's one of the later ones, and it comes down the body and serves a lot of the gut motility. So the vagal fiber is our main fiber for the parasympathetic nervous system. So the sympathetic nervous system activation is fight or flight. Parasympathetic nervous system is rest and digest. So increasing the firing rate of the vagal fibers is going to end up reducing the heart rate. We're also going to have an increase in the SA node responsiveness to acetylcholine. So remember that acetylcholine, in our postganglionic neurons, we're going to be having acetylcholine working as our parasympathetic nervous system neurotransmitter. So when acetylcholine gets released, it's going to tell the body to go into rest and digest mode. And by increasing the SA node's responsiveness to acetylcholine means that we don't have to change how much acetylcholine there is, but the SA node will recognize acetylcholine and have that much stronger of a response to any existing acetylcholine there is. So again, it's going to actually be the same effect as increasing the firing rate of the vagal fibers, and we're going to have a decrease in the heart rate. Unfortunately, with digoxin, it kind of seems like a miracle drug until you look at the adverse effects. So the adverse effects primarily are due to the narrow therapeutic range that digoxin has. We can have very severe dysrhythmias, especially coming from hypokalemia. So if we have someone who is predisposed to hypokalemia, they're going to be predisposed towards having an even greater potential for toxic digoxin levels and dysrhythmias. And because of the toxicity risk that is so high with digoxin, we're going to be having digoxin as our second-line drug for heart failure. We'll get to these in a bit. These guys right here. So things that are really, really, really important to remember with digoxin is that it does not prolong life. It also does not prevent or improve cardiac remodeling. So the drug itself doesn't do that. One of the benefits that might come about long-term from digoxin is the exercise tolerance, the ability to resume exercising. If they take advantage of that, that can potentially prolong life. And that can promote maybe some beneficial remodeling of the heart to sort of compensate for some of these heart failure symptoms. And it may also decrease life expectancy in women. I don't think they know exactly why that is. I don't know why it is, but it's important to remember. Where was that? All right, there it is. So with digoxin, there are a number of drug interactions, which we can all recognize just from the number of times Rachel indicates that digoxin's a drug that interacts with any number of other drugs that we've covered. So with diuretics, specifically thiazide or loop diuretics, not aldosterone antagonists, these can increase dysrhythmias by decreasing potassium ions. So remember that with thiazides, with loops, we conserve sodium at the expense, no, I'm sorry, I had to take a second to gather my thoughts again. So remember the diuretics, they're trying to get rid of water, and they're doing so by getting rid of sodium. And remember that in the collecting duct and the distal convoluted tubule, the body's going to try to pull back in sodium because they're recognizing, holy cow, we have all this sodium going through the loop of Henle and distal collecting duct, or distal convoluted tubule, collecting duct, etc. And we want to try to pull that back in. We're losing it for some reason. As they try to pull it back in, they're then going to dump out in exchange a bunch of potassium. So with that, we're going to have decreased potassium, which is going to promote the potential for toxic digoxin levels and dysrhythmias. ACE inhibitors and ARBs can be a beneficial interaction with digoxin because they can increase potassium levels. Because what do ACE inhibitors and ARBs do? They are somewhere along the chain of the RAS system. They are blocking something which will inevitably be able to reduce how much aldosterone we release. And aldosterone is going to collect sodium and try to conserve sodium at the expense of potassium. By blocking that, we can kind of hold on to more potassium over time. Calcium channel blockers are dangerous because they can increase digoxin levels. I don't know why. And then sympathomimetics can be problematic because they can increase the rate or the chances of experiencing tachydysrhythmias. So with digoxin, nursing implications, specifically patient education, is huge. We're going to want to teach them about the toxic symptoms and when to notify the PCP. We want to really encourage them to take advantage of being on digoxin by partaking in regular, mild exercise. We're going to want, as our job, to review medications for potential dangerous interactions because these are, I think they're even more than these potential drug interactions by quite a bit. So we want to make sure that we're going through and using our resources to try to figure out, are there any dangerous interactions going on here? We may need to, especially at first, check blood digoxin levels so that we can ensure that we're keeping them within that narrow therapeutic range. We need to make sure that we promote, like eating bananas, something to keep potassium levels in normal ranges, because if they start to dip down, there's a much greater chance of their experience toxic digoxin or dysrhythmias. And a really important thing here, come on, there you go. If you ever see the pulse go under 60 beats per minute, or if you see a rhythm change, hold the medication and notify the PCP, always. So when it comes to the toxicity continuum for digoxin, it's supposed to look like this. with this side being the common adverse effects and these ones being the later stage adverse effects. So early on, we're looking at anorexia, nausea, vomiting. These are going to be signs that indicate to you we need to check the digoxin levels. We need to check the potassium levels. We need to make sure that we're looking at confirming that this person's not within the toxic levels. On this side of the spectrum, we're going to be experiencing confusion, dysrhythmias, bradycardia, muscle weakness, vision changes such as that haloing that we can see around lights. This isn't very common, but if you have a patient who's experiencing it, you want to be on your A game immediately. Or if we're experiencing blind spots or blurred vision, any kind of vision changes. So this requires immediate action. This is going to be, we need to do something also. We just need to confirm that we actually do have or don't have toxicity. So vasodilators there are a number of them. Some may act on the veins, some may act on the arterioles, some may act on both. And they have multiple applications, including heart failure. That's about all there is to that slide. Dopamine is going to be our main other inotropic agent. And dopamine has a number of beneficial actions. So what it does is it promotes, it's a sympathomimetic, which means it mimics the sympathetic nervous system activation. So we can use this for heart failure, asthma, preterm labor, and the reason why for asthma is because with dopamine, this can help to cause some vasodilation because it's a nervous system activation. And there may be some other ones that I'm not necessarily aware of. For dopamine, the actions or its actions are dependent upon how high or low a dose we have. And each level of dosaging will affect different receptors. So at low doses, we're affecting only dopamine. And the normal range for dopamine is going to be about 2 or 5 to 20 micrograms per kilograms per minute. So with low doses, we're talking maybe 2 to 5, maybe a little more than that. We're affecting only dopamine receptors. At moderate levels, maybe around 8 or 10, we're going to be affecting dopamine and beta-1 receptors, beta-1 receptors being associated with the heart. At very high doses, maybe around 20, we're going to be affecting dopamine, beta-1, and alpha-1 receptors. And alpha-1 receptors, if I recall correctly, are going to be about vasoconstriction, which is going to help to increase blood pressure. Now remember, dopamine falls very high on that stepwise approach. So this isn't the medication that we're going to be going for to try to potentially limit the progression of heart failure. This is more often going to be used for comfort care and trying to maintain just some form of blood pressure to begin with. Potentially other uses as well, but that isn't my specialty. So therapeutic uses, we're going to be using it for heart failure to increase myocardial contractility and increasing cardiac output. And then it can also be used with shock, which you will cover more of, I believe, in acute 2. It's very important when given dopamine that we monitor them specifically for necrosis with extravasation because dopamine is very irritating. We also want to monitor for tachycardia, dysrhythmias, and angina because we're going to be activating the sympathetic nervous system with this medication. So if we give too much, which we have very high chances of being able to give too much, given the very broad range of dosing options, we can send them into very high tachycardias, very severe dysrhythmias, and cause a lot of chest pain. We have to remember that there are a number of drug interactions for dopamine, such as MAOIs, TCAs, some general anesthetics, but diuretics can be a complement to dopamine. Actually, I'm not sure why. I'll look it up at some point. For preparations and administration, One of the reasons why we have to be monitoring that necrosis with extravasation is because we're going to be administering it via IV, and we have to make sure it's diluted. I believe that it's normally given 50 milligrams in a 400 ml bag, or 50 grams. I don't. It's something similar to that. Normally they're given in a smaller bag, and they're diluted, which for us it'll be simply done by the pharmacy, I think, and administered via IV. Is that? Oh, okay. So that's it.